Hi, I'm Dr. Amol Gupta, and I want to thank you for joining me on another episode of the Medicine Mentors, where we interview masters in medicine, leading physicians at the top universities across the United States, to learn from their experiences and derive key insights, traits, and best practices that can guide medical students and residents. Today we have a very special guest, Dr. Amit Dayal. Dr. Dayal is an associate professor of medicine and an associate program director of the Internal Medicine Residency program at Loyola University. He joined the staff at the Hines VA Medical Center and the faculty at Loyola in 2006. He's been actively involved in medical education and has developed several novel programs during his tenure. He served as the Medical Clerkship Site Director and was recently recognized as Attending of the Year. Dr. Dayal is a Canadian, a Chicago White Sox and Bears fan, but most importantly, a husband and father of 2 girls. Thank you so much, Dr. Dayal, for giving us an opportunity to learn more about your life story and experiences.
Oh, well, I'm grateful to be here. Thank you.
I want to start by taking you back to your childhood. Who were some of your role models growing up, and what were some of the values that you imbibed early on in your life that you feel have stayed with you?
So both my mom and dad, as a child, for 2 different reasons, were mentors for me. My father was an educator of some renown in medicine, an ENT, and he was one of those guys that you would term as a walk softly but carry a big stick. So he wouldn't say a lot, but his message, and he's very consistent about understanding a situation and then offering a solution. And I really admired that. I also, being a kid, walk around the hospital with your dad, and everybody looked up to the guy. And that really fostered this idea of myself that, I want to be an educator. I really want to be one of those sort of professorial guys, just because of looking at my dad and the way people interacted with him. But my mom was different. And I think her story is the most inspiring story to me. She had wanted to be a urology resident when she was in medical school. And at the time, it wasn't such a good thing for a woman to be. So they told her she should probably be an obstetrician. And so even despite that, she pushed through, became an obstetrician, became a surgeon, and has always really advocated for women's rights and self-determination. So she's a huge role model for me. So those are my 2 big inspirations. And then one of my cousins, Ash Razdan, he's a pretty nerdy engineer guy. But when I was younger, he was 5 years older than me, and he taught me about excellence in what you do, how you approach things, how you make a system to be successful. And I really admired that in my elder cousin.
Your mom seems to have had a huge impact on your life. What are some things that you remember when you walk into a patient room or attend a meeting with your colleagues or the administration that your mom taught you early on?
She's always asked the question, why? Why are we doing? What's the process that got us here? And can you challenge yourself to be successful and master this or find out a reason why? So I take that with me everywhere. So you have to question why, and then you have to have the willingness to pursue it.
So after completing high school and as you got further down along on your path, what were some major events that helped shape your journey into academic medicine?
So in medical school, I met my 3rd year clerkship. I met John Shagrin, who was, I believe he was from the University of Michigan originally, but he was the chairman at Illinois Masonic. And he said, "Hey, Dayal, you're a smart guy, but you need to be more organized to be an internist." And it really stuck with me, this idea of becoming very organized, having the data in a certain fashion, and following this time-honored internal medicine, pertinent positives, pertinent negatives. I can still see and hear him talking to me as a 3rd year student. And it amazed me because he was an older chairman and he's taking an interest in a 3rd year student. So in medical school, that was huge. And he challenged me to be as good a medical doctor as I could be. The young residents I worked with, the medical clerkship and my surgical clerkship, were amazing. They taught me you have to show up and work every day. You have to put yourself out there and get the job done. And that was truly inspiring because when you're a 3rd year student, you see this 5th year surgical resident just really running a service and realize how you have to build up to it. So I was inspired by those folks. Yeah, for sure. Medical school, though, was John Shagrin every day.
You talk about Dr. Chagrin. Why do you think he had that affinity towards you?
I think that if you expressed effort and interest and you showed a similar sort of just true enjoyment of the subject. I think that they put a little bit more out. But for him, I think it was he would anchor to the students who were really participated in morning report, who are interested in bettering themselves. But I will say that he met with every clerkship student on every rotation and had an exit visit, which is pretty impressive.
One of the goals of this podcast is to understand mentorship and to understand that while technology has advanced, education has improved, mentorship seems to have weakened over the years from where it was 20 to 30 years ago. Something seems to have gone amiss. Can you help describe what that is?
So, one of our chief residents, Lawrence Mallow, about 5 or 6 years ago, he became chief resident and he walked up to me and said, thank you for putting me in this position. And I said, Lonnie, you got to hear on your own. And he said, no, it was some words that you gave while we were rounding when I was an intern that inspired me to be chief resident. And so I think that one thing that all teaching attendings or people in mentorship positions should understand is that even if they don't have a direct mentorship role with people in a long-term relationship like I have with several people, I think that what they say and what they do and how they hold themselves, if they hold themselves to that standard that they have, it really does make a tremendous impression upon the trainee. That's what I've done. I've been much more approachable, much more interested in hearing from the trainee, and then I've developed the mentorship role from there.
So now shifting to more of the mentee side, how can mentees create better relationships with mentors? What are some tips and tools that you can share?
So one thing is to see value in what may not seem like the most important thing. So see value in what's being taught. Because we want to know that Entresto is from the Paradigm trial, it's the best new heart failure medication. That's what you want to know about. But wouldn't it be a more lifelong skill to learn about communication with a patient?
Today it's so easy to access information. We can just Google. You have a question, Google. So a lot of times, the question is, well, what do I need a mentor for, right? I have the biggest mentor of all. It's $1 trillion company. Can you give us some perspective on that? What are some things that Google can't do for us? And when should we reach out to the mentors that are within our hospitals?
So it's a great question. So UpToDate, phenomenal resource. You can just type something in, or Google Scholar, you can type something in and get every paper known, and you can become an expert on treatment, right? You could say, well, this is the medication that we're going to use for cardiac amyloid. It's brand new. I know everything about it. But what is your practical knowledge about the application of that? Have you learned to communicate with your patient? One, because there's so many domains that circle around a patient that are independent of the medicine. So their IQ, their language, do they trust you? What is their religious background, et cetera? So have you been able to bridge that? You'd never be able to learn that from a book or from the net, but an attending or a mentor can show you their experience with a drug or a disease process. And also, I invest a lot of time into epidemiology, statistics of disease, and I get a perspective of the disease. While the resident will identify rheumatoid arthritis and identify the most current treatment for it, do they have the background knowledge and the pitfalls of that treatment? That becomes incredibly important for the student, is like to take that experiential knowledge and really be able to apply what they've read in a reasonable fashion. So yeah, you can learn a lot from the net. You can learn how to manage the most difficult diseases, but the experience and the application is lost, absolutely lost.
Some questions that commonly come up: how do I build trust with my patient? How should I treat my support staff? How do I balance my work, my life? Can you share with us how a mentor can help in some of these softer sides of medicine and may have helped you in your own life?
A lot of the residents will go into subspecialty or they go into hospitalist medicine from our residency. And one thing I tell them about, if you're going to be a hospitalist, know your nurses on the floor, know their first name, know something about them, and genuinely be there as a colleague and participate in their life at work. I'm not saying that you have to go to their house and have a barbecue, but I know my nurses in my clinic area. I know my nurses throughout the hospital. I know my nurses in the ER. Without those people, I can't effect good care and I will not find out what's wrong with the patient. So I take the time and the effort to know the staff, to know people who are in food services, all the way to the chief of staff. Successful health institutions are based on good, solid interdisciplinary relationships. So I always tell the residents, you have to know your staff. You have to be part of the hospital. You can't just be coming in, write a note in the chart and leaving. Watch your mentors. Watch your people that you consider to be successful doctors. How do they interact with the patient? How do they communicate with them? What words do they choose? What methods do they choose to allow them to assess whether the patient understands them or not? Incredibly important. One thing that I do with the students is when we go in a room, you're the doctor. I want you to do the talking. When you run out of material or you don't know what you're saying, just put your hand up. And that way we can see engaged, does the student know how to talk to the patient? Do they know about the disease? Because if you can't explain it to another person, it's easy to use the medicalese to tell your colleagues or your residents or your attendings, but that's a trick I employ with, not a trick, that's a tool I employ with the students for sure. I want to hear what they know and how they're expressing it. Burnout is a tragic thing, but you said the most important thing. How can you be successful? I'm successful because I took my father's model. My dad was a surgeon and he was home by 6 o'clock to eat with his family every night. As we got older, with sports or extra activities, we weren't necessarily always home for dinner, but he made the point of being there. And so the way I have my job structured is my daughters are in my bio. It says I have 2 daughters and I want to be there. And I feel happy and successful that I'm able to participate with their life. Medicine, surgery, whichever discipline you choose can take that away from you. And if you're not happy at home and you're not satisfied with the job you're doing there, it's very difficult to do that at work. And the most successful physicians I know are the people who have a good, solid, out of hospital life.
That's wonderful. That's a really good point. I want to understand when you walk in the room and you have 15 minutes, what are certain things that you may have started as a best practice, but have now really become second nature to you? Things that everyone should start to adopt or at least think about.
Well, the one thing is you have to give your patients a chance to say what they want to say. So we often walk in a room with an agenda. Heart failure, coronary disease, statin, afterload reduction. That's where I'm at. That's where I'm going in the room. This is my agenda. But the patient may be more concerned about something else. So first thing I do is I do talk with the patient and I do listen to what they say. And as opposed to talking at patients, talk with them. Certain patients I know I can sit on the side of the bed and talk eye to eye. It's a little tougher now with COVID, but I'm able to maintain an eye contact. There's certain patients I understand that they're very conservative. They want a very conservative physician. I always ask about themselves, much like with the nurses. I always ask something about themselves. And one bridge I have at the VA is I ask them about their service. And I'm fairly knowledgeable about American history and service. And that tells them that I care, that they're important to me beyond their disease process. One thing that we all have to be willing to say, and I'm sorry to say that we're not, is I don't know. And I can't tell you how often I've said, hey, Mr. Smith, I don't know what the answer here is. I'm going to try and figure it out with you, and we're going to work through this together.
This has really been great, Dr. Dayal. I really appreciate you taking the time to share these pearls of wisdom. 3 things have really come out of this interview. I'd say the first thing, and it was very interesting the way you said it, right? How can we as mentees see value in what doesn't seem immediately valuable to us? Because really that's the difference between logic and wisdom. And the wisdom part is, I don't see the immediate benefit, but somebody who's already walked this path is telling me to do it. So maybe I should give that a leap of faith and follow the process and experience before straight out rejecting it. I'd say the second thing is the tips that you gave us in walking in the patient encounter, where 1, we don't walk in with an agenda. 2, we don't talk at the patient, we talk with the patient. And 3, we're willing to say, I don't know. And these are really 3 tips that, I think if we all practiced more, there'd be a tremendous difference in the trust with patients. The third thing is this realization that the white coat we don carries this immense privilege, and that the earlier we recognize its value and its importance, I think the more serious and more sincere we're going to become about our profession. So I really appreciate these great wisdom that you've shared with us. And I want to thank our audience for tuning in with us here on the Medicine Mentors. Thank you for joining us as we learn from the Masters of Medicine.